Part 4, and there are only 6 parts to this lecture. We're going to look at do not resuscitate orders and advance directives. So what is a do not resuscitate order? Well, it's a form of advance directive telling everybody that if their heart stops, they're not going to be resuscitated. Many doctors will discuss this with their patients, especially if they're gravely ill. Many elderly people choose to be a DNR because when a younger person's heart stops, it's usually from a cause that's, well, not usually, but it's sometimes from a cause that's reversible. But when an older person's heart stops, it's usually because the heart is worn out. It's tired. It's lived its life. And many elderly people that I meet don't want that done. Elderly, I'm saying like 80 plus. So you may see an advance directive or a doctor saying DNR, comfort care only. That's a form of advance directive. We're not going to do anything heroic to help that person. Now, what about CPR? You are all qualified to do CPR, as am I. How good is CPR? 19 to 50% success rate. That in-hospital CPR, 19 to 57%. That's not that good if you consider the person's in the hospital at the time and they still are having 20 to 50% chance of making it. And only 4 to 24% of those people leave the hospital alive. So that's not good numbers. Many people, they think CPR is curative because, well, on TV, on all those TV shows, on Grey's Anatomy, CPR always saves them, and it doesn't. And so there's unrealistic expectations sometimes. So does CPR require consent? I mean, if you're going to do a surgery, you have to have a consent, right? Do you have to have a consent to do CPR? No. Just like you don't need a consent to put in an IV or to pass medications. Can the patient refuse CPR? Of course they can. They can refuse anything. So is CPR a treatment or a right? A treatment or a right? My opinion, I think it's a right. You can choose to it. You can choose to have CPR or not. So I think it's a right. But just my opinion. Now, what about a person who has a DNR bracelet on and it says DNR, and you walk into the room and they're not breathing and you start CPR on the person? You could be charged with assault and battery because you are doing something against their wishes. So CPR is, you need to know what's going on. You need to always be aware of your patients and who they are. Every patient is different. You can't assume anything. A 90-year-old person, you can't assume they're DNR. A 40-year-old person, you can't assume they're not DNR. You have to know your people. So what if CPR would be a futile event? I mean, if the person, if the patient is so ill that CPR would be a waste of time, what do you think? Should the person have the right to demand CPR anyway? Well, they do. Even if it's going to be ultimately futile, they do. But that's a teaching moment. That's when we need to talk with the family, talk with the patient, communicate with the doctor, maybe get a chaplain involved, and make sure everybody understands what's going on. CPR is not a cure-all. We all know that. And we need to make sure the patients understand that. Now we want to look at quantitative futility. This is when research suggests that they will have a less than 1% chance of producing the desired physiological effect with CPR. That is quantitative futility, or when personal, professional, or public opinion suggests that while a therapy can achieve a desired effect, it will not actually produce the desired effect. So a situation such as persistent vegetative state, where CPR can bring back cardiac function but not change the persistent vegetative state. Those are quantitative futility examples. So so in situations like that, that has to be very clearly explained to everybody. Now there's qualitative futility. And this is when, if CPR is performed, the long-term results will still not achieve the desired outcomes. CPR for sepsis, CVA, cancer, pneumonia, GI bleeding, a 1 to 6% survival to discharge, and 78% of those people will require permanent hemodynamic monitoring, ventilator, or dialysis. Is that a successful outcome? Those kind of data must be made clear to the patient and family, that even if we do CPR, the person will not have a high quality of life. Technology can keep the body alive a long time, nearly indefinitely. But that doesn't mean the person is living or has a life. So that's what we need to explain. So again, talking about CPR and on TV, CPR on TV, it's a 50% survival rate, but the average age is 36 on TV. And the typical cause on TV, trauma. Remember when I said younger versus older? A 36-year-old who needs CPR has a better chance of surviving than an 86-year-old person. So again, know your patient. Now, what about portable DNR orders? Portable meaning a person could be at home and being DNR. Portable DNR orders allow emergency medical services personnel to not start CPR, but allow them to provide other levels of care. In Wisconsin, for that to happen, you must be 18 or older. You must have a terminal medical condition that makes CPR unlikely to be successful, such as severe heart, lung, or brain disease, and a medical condition that would make CPR cause more harm than good. So, in Wisconsin, there are some specific criteria that you must meet. Now, must have a terminal disease. I want to talk about that for just a second. What does that mean? Well, it means a disease that could kill you. Yeah, okay. Let's look at diabetes type 1, insulin-dependent diabetes. Is that terminal? No, not as long as they keep using their insulin. But if they stop using their insulin, what happens? Now it can become terminal. So we have to use the word terminal carefully and understand what we're talking about by terminal disease versus treatable disease that could lead to death. About half the states allow out-of-hospital or portable DNR statuses. So if a person with a portable DNR status is at home and they go unresponsive, EMS can give assessment. They can provide help with choking and airway clearance. They can give oxygen. They can give medications for dyspnea. They can be very aggressive with pain management. They also provide grief counseling and other appropriate services to family. Both healthcare provider's signature and the patient or surrogate must sign the DNR order, the portable DNR order. Patients receive a copy of the original order and must wear some sort of wearable identification. And patients must receive 2 forms of proof of this order, so that and then most states also require position that EMS personnel perform CPR if the family persistently and strongly requests it, even if the person has a portable DNR order. That's where problems develop. That's where there has not been good communication within the family. I have seen that in the hospital where a person wants to be DNR, and their heart stops, and a spouse says, "No, I want you to do it." It's challenging. The person has clearly said no DNA, no CPR, but when they become incapable of participating in the care, when they become incapacitated, when their heart stops, their spouse is their next decision maker, and they can say, "Do it." Communication. Education and communication is what we need to do. So policies that protect patients' rights to accept or refuse CPR should be written. So DNR orders that allow patients across settings and services. So there should be clear understanding of portable DNR standards. There should be an appeal process in case a physician in charge is unwilling to write the DNR order. Patients and surrogates who request a DNR order must have, must understand the consequences and situations that this may bring. Hospital policies should allow patients and their surrogates to write the right to refuse CPR, even in the absence of a written or verbal order from a physician to withhold CPR. They can be rare, but they do occur, and I've seen that happen also. I've seen that where a gentleman, he was in the hospital, bad heart attack. The doctor had not yet talked to him about DNR status, and his heart stopped. And the wife, when he arrived, the wife says, "Don't." And we went along with that. So a nurse or a supervisor should be able to authorize that based on surrogate statements, surrogate decisions. Do we need two witnesses and two disinterested witnesses to observe and authorize DNR? Or should that requirement be removed? It's nice to have that two witnesses, the two disinterested witnesses for a witness, but if that would impede the patient's best interest, that should be removed. What happens when there are multiple children that are present in a situation like that? Who do you talk to? These are system concerns that needs to be addressed system-wide, not just in one specific situation. These are ethical dilemmas. That's it for part 4. Come back for part 5.